So thanks very much. I hope the right screen is actually shared and everybody can see the presentation. Thanks for the invitation. I'm talking about brain metastases and the road to resection and beyond. The title was actually produced by somebody else. So just a short preface: for many of us neurosurgeons, brain metastases are somehow considered to be the poor cousin of glioma. So I don't think that's a justified point of view, because it's a really very important part of our daily business. So that's my agenda. I'm briefly talking about the road to resection of brain metastases, and then just talk about the effects, what we actually can achieve by resection, some neurosurgical paradigms and the truth behind, and then briefly look at some future perspectives regarding that. If we look at the road to resection, why we do actually take our brain metastases, the whole basis is actually found in a couple of randomized controlled trials, which are from the 1990s, which compared the survival in patients with singular brain metastases receiving surgery and brain radiation versus people receiving brain radiation only. And they saw actually in the majority a survival benefit. And the third study was controversially discussed because there was a large crossover trial. But we have to keep in mind that these are really old data. The patients reported on were treated in the 1980s. There was a CT-based area in a pre-stereotactic field, and all these patients did not receive any systemic treatment, nor they had any real good options at that time. So we have to keep in mind that the oncological world today is completely different than the one in the 1980s. Like, the computers changed completely, and still, however, some of the dogmas from that time still circulate around. And the first dogma you still find among neurosurgeons is that the cerebral disease is the most important aspect in patients with metastatic disease, and actually it will finally kill them. And if we look in the data, that's not true, because if analyzed at all, we see that the majority of patients with metastatic disease and brain metastasis actually do not die from the brain metastasis, but they die from a non-neurological death, from their systemic disease progression. A second point is that up to now, there's no proof for a real good correlation between a good local cerebral control and survival of these patients. We tend to mix that up with gliomas, but actually that's not correct. So keeping the brain clean does not lead to a longer survival per se. So we have to keep that in mind as well, because in these patients, the brain is just one battleground in actually a systemic disease war. And we tend to focus very much on the brain, but it's not the only theater where there's something going on. So the consequence for us as neurosurgeons has to be, we have to implement our treatment in a comprehensive oncological concept, no standalone solution. So why should we resect brain metastases at all? To answer that question, we have to look into the prognosis of these patients, and there have been several prognostic scores within the last decades. That's the oldest one, the RPA classification. You're probably all familiar with that. And actually, it's very simple. It splits up in 3 different prognostic classes. Class 1 has quite good prognosis, and class 3, they're very, very poor in their prognosis. They die very soon. And the major switch in this scoring is the clinical status, so measured by the Konofsky score here. So people who are not able to fulfill their activity of daily living without any help have a poorer prognosis, no matter what else comes into place. And also in more modern prognostic assessment scales, that's one from 2011, the first one focusing on different tumor entities, we see that the clinical score is present in all these patients, and in some of those, it's actually the only relevant factor for the further survival of these patients. So why does this matter to us as a neurosurgeon? because that's actually what we can do in this disease. The major impact of a resection of a symptomatic brain metastasis is symptom relief and an improvement of the clinical score. And this has been shown in several larger trials. And just two examples: we have a young patient with a lung cancer with a quite positive molecular profile, and he has a severe hemiparesis, which makes him bedridden by centrally located metastasis. You can resect these metastases quite safely, and this patient will recover tremendously fast after surgery and will be up and around and will be able to receive their further treatment. In a similar case, breast cancer patient with a large mass in the posterior fossa, severe ataxia, and actually the imminent risk of CSF occlusion and elevated pressure in the posterior fossa. You can resect these tumors and actually improve the clinical condition of these patients. So why is this relief so important? And we frequently subset that under other aspects of reality is also doing better, but actually that's a really, really important point, because the resection of a symptomatic brain metastasis with an increase and an improvement of the clinical score of this patient reduces the risk for other unfriendly diseases, complications, deep venous thrombosis, pneumonias, urinary tract infections, and so on. And it also increases the access to other treatment modalities like radiotherapy and systemic oncological treatment, which in turn is actually nowadays, if you think of all these molecular treatment abilities and the immune checkpoint inhibitors, a very strong independent factor for overall survival of these patients. So another dogma which is still going around, and it's actually still part of some guidelines, is that only for single or solitary metastases, surgery is a good option at all, and we should not operate somebody else. And that's also probably not true. There's no high-level evidence for that, but probably it's the wrong point of view. Just let me give you a brief example. That's another patient with a hemiplegia, and he's got 5 brain metastases. And the symptomatic one is actually just this one, and he has quite good treatable molecular profile. He has got an ALK translocation, a very high PD-L1 expression. So from an oncological point of view, this patient has a very good treatment profile. So a treatment concept, although he has got 5 brain metastases, maybe just take out the symptomatic one. This patient did recover very, very quickly. Within a couple of days, he was up and around, and you can just choose some other local treatment modalities, focal brain therapy or radiosurgical treatment of the other tumors, and after that he receives the actually targeted therapy, an ALK inhibitor. So we should just get away from this thinking that just one is the right thing, because we have growing evidence also in some of the newer prognostic scales that the mere number of a brain metastasis is not or only scarcely relevant for the survival in the era today where you get lots of different molecular targets. And just to remember, up to date we have no consistent correlation between a good local cerebral control and survival. And again, the consequence would be we have to make a treatment decision in a very close communication with our partners from oncology and radio-oncology. The next dogma, which still is alive, is that brain metastases show a well-delineated growth, and therefore surgery only leads to a good local cerebral control. That's definitely not true. It has been shown in a variety of studies, and the largest one was the Cocker trial from 2011, an ERRTC study. And here they compared the local recurrence at the initial treatment size, and the yellow curve is the surgery-only curve, and the other curves are radiosurgery or surgery plus brain radiation. And we see that surgery alone performs very, very poorly. So we have a very early local recurrence if we just resect a metastasis and just think we have done the job at this place. And the reason for that is that different than we thought previously, that almost all these tumors, they show actually a high degree of infiltrative growth, although we do not see them under the microscope, and we do have a poor local control after surgery alone. Whether this is really important for survival at all, we don't know yet. That's a different issue. We will not address that here because we don't have the time for that. So You might argue, okay, if it's not sufficient to take out the visible tumor, should we aim at a supramarginal resection, super radical? So it's kind of trendy in glioma surgery right now. Well, you could do. There's some smaller series reporting that, but you keep in mind the clinical status is the major factor for the further survival. So do not trade radicality for function. There's no use in that. The next point still very often still comes up in some tumor boards, that medical cancer treatment is not effective in the brain. That's also something which is not true, because even the first trials focusing on different targets like ARC translocation, BRAF, you all heard of them about different tumor types, they see in the very first trials in the first substances that they have a quite high, quite variable, but quite stunningly high intracranial response rate. So what we also know from some nuclear medicine experiments that these small molecules and also antibodies used for immune checkpoint inhibitors may actually reach the brain metastasis. They do pass the blood-brain barrier. They can actually have an effect in the brain. So is that relevant for us? Yes, it is. I think so, because that brings up actually a future role and a new perspective also for neurosurgery. Because within the last couple of years, what was seen is that the molecular profile of the tumors throughout the body is actually different, although it's all the same tumor. So the breast cancer in the lung may have a different profile on a molecular base than the abdominal metastasis, the lymph node metastasis, or the brain metastasis. So a targeted treatment actually may not hit all these different tumor sites. And even more, there were some few reports that in the same patient, in the same brain, different metastases actually showed a different molecular profile. So we do have an increasing evidence that the mutational pattern actually will differ between the primary tumors and the metastasis during time and during treatment, because treatment obviously exerts a selection pressure on the tumors, which may lead to a lot of different resistant mechanisms. So that's just a short example. There's a young lady with a malignant melanoma, BRAF mutation, and she had a single, very small brain metastasis, which was treated by cyberknife radiosurgery, and she got a targeted treatment. For quite some time, she was stable locally and systemically, and she had a recurrence 2017. And a tissue update still showed these the BRAF mutation. So sometimes the resistance occurs a step down. So the treatment was actually intensified by a MAC inhibitor, and she was again for a year stable and had a local recurrence about a year later. And we took out this tumor, and now it's a completely different tumor. It's wild type for all the targeted, but it has a very high expression of PD-L1, so it's actually a very good candidate for an immune checkpoint inhibition. So the medication was changed, and she was doing actually pretty well. Had another imaging change after another 6 months, which was re-biopsy. There was no tumor, just inflammatory tissue, and she's actually still doing well, which is, compared to a decade ago, it's a wonder that melanoma patients can make this course nowadays, but it's not really an exception. So I think the future role for neurosurgery will be more and more a repeated tissue analysis, maybe by resection or by stereotactic biopsy, because we can contribute valuable information for the oncological concept and modulate the treatment decision, and we can contribute valuable information to the ongoing scientific approach to these resistance mechanism development, which is really, really interesting and fascinating. So coming to an end, I think neurosurgery for brain metastasis has a couple of very important aspects. The most important aspect is we can alleviate symptoms and we can bring patients back on a treatment line. And we do not change the cancer course by our treatment. That's ridiculous if we still some people think that. But we can give them time, because sometimes we can do time-saving surgery by big lesions in the posterior fossa, and we can contribute a lot of valuable information in the future for scientific understanding of cancer. So resection is very valuable in a comprehensive oncological setting, and I think that's a very, very important aspect. Thank you very much.